Childhood Development at the Department of Health and Human Services. I'd love to welcome all of you to our third now webinar in our Expulsion and Suspension Prevention series. We still have folks joining on the line, so we're going to wait just one more minute and then we'll get started. Can you guys hear me?
Yes.
This is a reminder, all the lines, presenters, please mute your lines until we get started. It's going to be just another minute. Hi everyone, this is Chantel Meek again. We will get started. Before we jump into the content, just a few logistical reminders. All of your phones are on mute, except for the presenters. You can ask questions through the chat function, and we will get to as many questions as we possibly can. At the end of the presentation, we have a good chunk of time dedicated to Q&A. All of the slides will be posted online. They're going to be fully recorded, so the actual presentations and the slides will be online. It takes us a little bit of time to do that, so give us a few weeks, but eventually all of this will be online. So with that, I will jump right in. So as I mentioned, this is the third webinar in our series of 4 that is looking at different issues of expulsion and suspension prevention. Today we're going to take a big deep dive into program quality in the professional development field. We're going to focus on early childhood mental health consultation and the pyramid model, and really look at diversity-informed tenets of working with children and families. So before we start, if you have joined the other 2 webinars, you have seen this slide. We like to set the context for why we're focusing on expulsion and suspension. Everybody on the line likely knows the importance of the early years and how critical those early years are to the rest of a child's life. We know that often the kids that are expelled from early education and from school are usually the ones that need the most support. We also know from the K-12 literature that kids who are expelled or suspended face a whole array of maladaptive outcomes. As you see here, 10 times more likely to drop out of high school and have a whole host of other issues. We also know that expulsion and suspension early in a child's education only predicts it again later in life. And so that paired with the rates that we now are seeing, for the past 10 years, I think Dr. Gilliam's study first shed light on the issue and how high the rate is actually in early childhood settings compared to K-12 settings. And the recent data released by the Office of Civil Rights from the Department of Education highlighted not only the rates, but really the egregious disparities that we're seeing in the issue. So all of these issues combined really kind of merit all of our attention, and that's why we're focusing on it. For the federal policy statement on expulsion and suspension, we built it around this framework and these pillars of prevention, and that's what we've kind of molded the webinar series after. Looking at fair and appropriate policies, which we focused on last week, setting goals and tracking data, which we'll focus on next week, family partnerships, universal screening, and really the last 2 on the left there, a highly skilled workforce and access to specialized consultation. really making sure that our workforce has the skills but also the backup support that they need to build their capacity to be able to work with all children. So with that quick context, I will hand it over to Linda Smith, who will provide a few framing comments before we jump in.
Well, I thank Chantel for this, and thank all of the people who have been working on this series. It is getting a lot of attention, and justifiably so. I've heard from a lot of people about how important they think this work is. I also want to thank in advance our very distinguished group of presenters today. They are taking time out of their busy schedules to be with us and to provide information for all of you. So with that said, today we are going to focus on the two pieces that Chantel referred to, the access to specialized consultation and the highly skilled workforce. And just to frame the issue, I want to back up and say that, you know, in the beginning, it really does start with the people in the programs who are providing the day-to-day care and early learning experiences for our children. And sadly enough, a lot of these people have not had an appropriate background or the training they need to work with children who have challenges themselves, or with some of the families that may have challenges. So as a starting point, and I'm really grateful to see some of the work that's going to be, you know, talked about today on the CEPL work that's been done, is that it has to start with our workforce getting training in what good child development is. And that said, in what is developmentally appropriate behavior, because in my experience so often what the children's behavior is appropriate. The adult expectations of children is sometimes where we go awry. And so we want to have that framework of where we start working with our people in our programs early about what is good child development, what is appropriate behavior, and what are appropriate expectations of children at the ages that they are. Because when those things aren't in place, it goes negative very quickly. And I think quite often now about what a child must experience if if for some reason a child is asked to leave a program, or the parents are asked to take a child out of a program, expulsion or whatever you want to call it. The stress that puts on a family is sometimes crippling, and as a result, that stress spills over to children and makes for even a situation that is difficult even worse. So I want to remind people, as you think about this, to think about what happens to the child and what happens to the parents with our failure to do some of these things. So I think it's very important that we start looking at the workforce and how skilled they are, and that we look at how we're going to provide the support that the workforce needs when they need higher levels of help and intervention. So I think with that, I'm going to turn it over back to Chantel, who will introduce our first speaker. But I can't tell you enough that, you know, when these things go wrong, they go horribly wrong for a lot of people, not just, you know, one or two, but for families and for parents and for children. And we really do need to look more closely at this. So Chantel, why don't you go ahead and introduce the first speaker.
Great. So our first speaker is really going to give us an overview of the pyramid model. Dr. Mary Louise Hemmeter is a professor at the Department of Special Education at Vanderbilt University. So Mary Louise.
Can you hear me?
Yep, we can hear you now.
Okay, great. Thank you. Well, thank you so much for having me on, and Linda just framed my comments really well, so I appreciate that as well. So I'm going to spend just a few minutes giving an overview of the pyramid model and a little bit of time giving an overview of some research we've done on the pyramid model and thinking about what that means for being able to support programs and families to implement the pyramid model. So our work on the pyramid model really grew out of work on positive behavior support, positive behavior interventions and support, which really is grounded in a focus on prevention. And so it's entirely consistent, of course, with the tenets of the statement. But our kind of guiding principles around the pyramid model is that we have a focus on prevention, that our power is really in preventing problem behavior, that we have a focus on supporting families and providers who work directly with children, and that we're developing interventions and supports that can be implemented in children's natural environments, whether that's childcare, home, school, community, church, wherever children spend time. So the next slide, please. So the pyramid model is really a promotion, prevention, and intervention framework. And as I said just a second ago, really, really a focus on prevention. And I think as this relates to children with problem behavior, that our goal is really to help caregivers, whether those are parents or teachers or providers, understand the meaning of children's behavior and respond to that in ways that are proactive and preventive. And so rather than talking about children being defiant or controlling, we think about what is the message of the child's behavior. What is he trying to tell us? Is he trying to tell us he's sad or mad or scared or bored? And then respond to that in a way that helps him communicate that message in a more appropriate way. And when we do that, we decrease our risk for interpreting children's behavior in some other way that might not be really what the child's behavior is about. In terms of the focus on families in the pyramid, our belief has always been that we have to focus on building relationships with families around promotion and prevention, so that when there's a problem behavior, or if there's a problem behavior, we're addressing that in the context of an ongoing relationship with the family. And I think Walter talked about that when parents and teachers are willing to work together and have a good relationship, we don't see these issues around suspension and expulsion. So I'm going to run through each level of the pyramid really quickly to just make a couple of points. So the first level of the pyramid, you can go to the next slide, is really around relationships, and I was just talking about that. I think that our focus is really on being positive. Our focus is really on being supportive. Our focus is really on creating a context between parents and teachers and children and each other that provides a context for them to learn more appropriate behaviors. We think that we need to build relationships with families around the bottom of the pyramid, around promotion and prevention, to help them understand the importance of that, as well as we believe that the real basis of addressing children's behavior is in first establishing a relationship with that child. You can go to the next slide. I talked a little bit about, so the base of the pyramid is the relationships. The next level is really about environments and how we set up environments so that children are successful, so that children can be successful. And Linda was talking a second ago about the importance of good developmentally appropriate practice, and we think that's really about what makes an environment supportive of children, and what helps prevent children's problem behaviors is to have good developmentally appropriate environments. And as Chantel said, that we have a kind of ongoing way of monitoring whether those environments are in fact adhering to recommended practices. We also think, and next slide, we also think that this is important around supporting families. And so we know that for children who have problem behavior or who are at risk for problem behavior, that having consistency and predictability and knowing what the expectations are of environments is important at school or at childcare, but it's also important in homes. And so what are we doing to help families know about the importance of consistency and predictability and communicating expectations to children? And so the base of the pyramid is really rooted both in wherever the child spends time, but certainly in his child care preschool setting and the home. The next level of the pyramid, whether we're talking about home or school, is being intentional about teaching children social skills and emotional competencies. So not assuming that just because children come to school they're going to learn to be social, but really being intentional about teaching them about communicating emotions, problem solving, social relationships, and giving them lots of opportunities to practice that. We also want to help families do that with children at home, and so the next slide will really talk about these same issues. You can go to the next slide, but how we support families to support their children's social emotional development at home. Okay, the next slide is really about the top of the pyramid. And so this is really about what do we do when we've done those levels that I just talked about really well and children's behavior is persisting, their problem behavior is persisting. And so one of the really important things I think here is making sure that we are in fact doing the bottom levels of the pyramid really well. And when we do and we have children whose behavior persists, then we have a really systematic, developmentally appropriate, positive way for developing behavior support plans for children who need them. Oh, go back a second. Yeah, and so I think just a couple of key points about that, the top of the pyramid intervention is that it's team-based. We expect that families and caregivers and providers will be engaged in that process. We believe that it should be based on an understanding of each individual child's behavior, and we believe that it needs to be focused on prevention and promotion again, but in a more individualized way. All right, so now you can go to the next slide. So that's a real quick overview of the pyramid. I think one of the things to know about the pyramid model is that it's a fully developed intervention. We have training materials on a number of websites, and you see them here, where Linda spoke about the work we did on CEPHL around the pyramid. So we have training materials that are fully developed, that have been validated and used. We have implementation guides and materials around training providers to use it, and we have a tool for measuring whether people are doing that with Fidelity. So the next slide, what I want to do here is talk real quickly about our research. And what you really need to pay attention to here is really just the red numbers. And these are studies we've done across child care, Head Start, and pre-K classrooms. And what you see is that when you go into classrooms where providers have not been trained to implement the pyramid model, they're implementing about 40% of the practices. And if you think about a lot of those practices being just good developmentally appropriate practices, this is a relatively small number of practices. Further, if you look at the ranges are what tell us that we really need to be doing some professional development around this. And so to address this issue, you can go to the next slide. We've developed a model of coaching that we refer to as practice-based coaching that is firmly rooted in identifying the practices you want people to implement and supporting them to implement those practices with fidelity. You can go to the next slide. So we use this model to train teachers. These would be to train early childhood providers to implement the pyramid model. And what you see in this slide is the results of the changes in teacher behavior. And so this is the extent to which teachers who received training and coaching on the pyramid model implemented those practices, so that would be the darker line. And the bottom line are the teachers who didn't receive training and coaching. And so over the course of a year, we don't see any change when teachers, even though they could be getting some other sort of professional development, when we measure their implementation of the pyramid model practices, we don't see any change. And for teachers who receive training, we see significant change that results in change in child behavior. So if you go to the next slide, I just put in one example of children's behavior. I apologize for the sirens. There's a hospital right behind me. But anyway, and so this slide really shows you the red line would be teachers who did not, the children of teachers who did not receive training and coaching, and the blue line would be teachers who did receive training and coaching. And so what you see is not only do teachers get better, but when teachers get better, children get better. And so this graph really shows children who have problem behavior. It shows improvements in their social skills. We also see improvement, teacher-reported changes in children's problem behavior for children who have problem behavior, and social skills for all children in a pre-K classroom. So even those children who don't exhibit any kind of social, emotional, or behavioral issues, the intervention still results in significant improvement in their social skills. So you can go to the next slide. So just a couple of conclusions I want to make from these data, which I think is really important, is first of all, fidelity matters. So when teachers implement the pyramid model with fidelity, we see changes in children's behavior and social skills. We have some evidence that the better teachers get, so meaning higher fidelity results in better changes. And so we know that we've got to provide some support to teachers to get them to fidelity. So if you remember that one graph where control teachers who didn't receive training, their data were just flat, it's clear that to get teachers to some level of fidelity that we're going to have to do some systematic training and coaching. And one of the things that I would say about the coaching model that we use is that we also examine the extent to which we implement the coaching with fidelity. So we measure dosage and we measure adherence to a protocol, meaning that our coaching is done at a high level of fidelity and is based on a research-based model of coaching. But I think kind of the bigger picture about all of that is that when we support teachers to implement the bottom levels of the pyramid, we have very few children who end up needing individualized support plans, and that's really important. And so even programs who think they have a lot of children at the top of the pyramid, when we've been able to support teachers and caregivers around the bottom of the pyramid, we end up with very few kids at the top. But it's clear that to get there, teachers, providers, families need support around the bottom levels of the pyramid. Okay, next slide. So I just want to, just in conclusion, say that, you know, one of the things I think we found from this research is the importance of both the quality and dosage of the coaching that teachers receive, and they get a lot of coaching as part of this research. And so one of the questions becomes, how do we deliver that level of coaching to every teacher when we don't have research dollars to support it? And so one of the things that we've been working on is, how do you support a whole program to implement the pyramid model? And that's what this slide represents, which is, what are all the components that programs have to implement so that teachers can implement the pyramid model with fidelity? And I think that the two things that I really want to point out about this slide before concluding is that the first is that there has to be a program-wide commitment, and that means that there's a program-wide commitment to supporting all children in that program. And so I had a director one time say to me, when I asked her about suspension and expulsion, she said to me, "We expect all children to be successful here." And then she paused and she said, "And we expect that we're going to have to provide support to teachers and families in order for every child to be successful here." And so I think one thing we've really got to work on is, how do we get programs to make a program-wide commitment to all children being successful in that program? And then second, how do we help programs make a commitment to knowing that every teacher, provider, and family in that program is going to need some level of support to be able to support children to be successful in that program? So we see that kind of scaling up coaching can be supported by program-wide implementation. So if everybody in a program is committed and working on the same thing, that those providers might need less coaching than if the program as a whole is not supporting and supportive and committed to that overall commitment to helping all children be successful here. So we've kind of done this program-wide model. Now we're thinking, how do you scale that program-wide model up? And that's where Barbara is going to take over.
Great. So next we have Barbara Smith with the Pyramid Model Consortium, who's going to tell us a little bit about what that looks like at a statewide level. And we're going to use Minnesota as an example. So it's going to be a spotlight on Minnesota. Barbara?
Yeah, hi everybody, and again, thank you for this opportunity. We are going to talk about Minnesota within the context of the state capacity building model that we've worked with over 20 states now, building the state capacity to support the programs to reach fidelity with the pyramid model. Next slide, please. So if you think about what Mary Louise just said, building that program-wide capacity with an internal coach with support from some expertise from the outside, what is the role of the state in ensuring that that happens? I mean, let's face it, there aren't a lot of people sitting around in early childhood programs with nothing to do that can now become an internal coach, and that the programs now can automatically figure out the pyramid model practices and how to implement them and take data without some kind of external support and coaching and technical assistance. So for over 10 years now, we've been working in states and learning from those states about how to build the statewide capacity to ensure that the people at the child level, number one, know about the pyramid model and the practices, and number two, can implement them with fidelity. The program can take data to ensure that the right people are getting training and coaching, and that we are, in fact, seeing the outcomes for children that are promised by these practices. So we've worked now with many states, and I'm thrilled to be able to share the story of Minnesota, but they are one of the states that are doing this work. Our model for building that state-level capacity has 4 major elements, and these have been honed over time through the SEPL work and the Technical Assistance for Social Emotional Interventions, TAXI, funded by the U.S. Department of Ed, and all the states that we've worked with, and now the states that the Pyramid Model Consortium is working with. These 4 elements are working for the states that we've partnered with, and we've honed down and tried to make as clear as possible what we've learned really will work for the state to build the professional development support programs need. The first element is a state cross-sector leadership team, and we're going to go into each one of these with examples from Minnesota. The second major element is a master cadre, a state master cadre of professional development experts. We want to make sure that the state has the expertise to provide the training and technical assistance to programs statewide to reach fidelity. The third element are demonstration sites, a handful of high-quality, high-fidelity programs that people can go and visit. And let's face it, if you see it, you're more likely to believe it. If you're able to talk to an administrator or a teacher or a family member about what were your challenges and how did you overcome them, you're more likely to replicate. So a handful of high-fidelity, high-functioning demonstration sites. And the fourth element and the key element is data decision-making at all levels, at the child level, the program level, and the state level. Next slide, please. So the state leadership team, I'm going to spend a little time on this because this is the hub of the action. We have learned through implementation science, right, that training alone changes very little, very few adult behaviors. Training supported by coaching results in much better adult behavior change and high fidelity of practice. So the state has the job of making sure there are the resources, the public awareness, and the public will to ensure that all programs have that kind of support. So the state leadership team is cross-agency. We've learned that if you get over about 15 people at a table that meets regularly, you can't make efficient decisions. And we can probably represent most of the stakeholders within 15 people. So it's a committed cross-agency group, cross-agency because children are everywhere, right? And if the pyramid model is working, we want to make sure it's wherever children are. Because of implementation science, we know that high fidelity implementation takes years. So the state team needs to commit to a multi-year effort. The state team agrees to meet monthly. They use effective meeting strategies. That's part of our capacity building. We train on what makes a meeting work so that people don't mind coming to these meetings and indeed are excited about it. We use implementation science. We know that it takes years. We know that there has to be local capacity. There has to be state capacity. We know there has to be data and fidelity. The state team establishes the demonstration sites. The state team establishes that master cadre of technical assistance experts, and the state team sets up data systems and reviews data and makes database decisions. The state team secures the resources necessary for making sure programs have the support they need, and they provide that infrastructure primarily through that master cadre, and we're going to talk about that in a minute. And the state team builds political investment. As the efficacy data starts coming in from the programs, the state team has a plan for using that data for building political will to get the resources necessary to go statewide. They ensure system integration. As we all know, that's really important because children are in multiple systems and sometimes in multiple systems every day. And the state team develops a written plan to sustain the effort and to scale it up statewide. And the spotlight on Minnesota. So almost 5 years ago, we started working with Minnesota. In fact, Deb Perry was one of our consultants working with Minnesota. And they established that cross-agency state leadership team that made the multi-year commitment. Next slide, please. So the master cadre, one of the first things that the state team does is they select a master cadre of training and technical assistance professionals. They're carefully selected. They represent the cross-sector. They're regionally located. So if you see where I'm going with this, the state is building a professional development system, a technical training and technical assistance system through this effort. We make sure that we build their expertise in pyramid model practices as well as implementation science, high-quality professional development skills, and technical assistance skills, which are different from training skills. We mentor them for a couple of years, and by the time we leave a state, that state has people who are so expert on the pyramid model practices as well as how to provide the training and technical assistance to local programs to ensure that the programs can reach fidelity. In Minnesota in 2010, the state leadership team identified 10 members of the master cadre and we began mentoring them, and they began learning the practices as well as the implementation model and how to provide technical assistance. Next slide, please. Also in that first year, the state leadership team identifies a handful of high-flyer demonstration programs. These programs they agree to partner with the state team to reach fidelity, to provide data, and in relationship to that partnership, the state team provides them the expertise and the support for the first couple of years from the national folks as well as their local master cadre. The demonstration programs also help to build the political will. They help the scale-up and sustainability effort because they are letting people come and visit. They're providing tours. They're providing data. They're providing presentations. So they really are the people at the ground level that are talking about how to make this work and what the outcomes are and what the good news is. They also ground the work of the state team in what are the challenges to doing this, what are the budgetary challenges, what are the staffing challenges. So in Minnesota, again, in 2010, the state leadership team identified 3 demonstration programs. Those demonstration sites established a program leadership team, an internal coach, and began to collect data, do training, and coaching. And again, for 2 years, the national folks were there to support them as well as their master cadre training and technical assistance person. The 4th element is data decision making. Outcomes are identified, fidelity and outcomes are measured, and data are summarized both at the program level and the state level so that it can be used for scale-up and sustainability. Data collection and analysis is ongoing. The program leadership team has a person that is the data coordinator, and again, for the first 2 years, the national TA system helps that person collect data and interpret it for their program leadership team. In Minnesota, between 2011 and 2015, they have set up a data system where they are collecting data at least once a year, in many cases twice a year. They're summarizing that data over the years and across programs, and they have used the data to continue to plan, implement, scale up, and sustain the effort. Next slide, please. Some of the tools, I'm not going to go over all of these, but we have tools that measure systems change, and that's at both the state level and the program level, and they're called benchmarks of quality. And the state leadership team or the program leadership team uses the benchmarks of quality to monitor their state planning or their program planning and to develop an action plan. We have fidelity measures. The TPOT, or Teaching Pyramid Observation Tool, is the fidelity measure for center-based programs and preschool, and the Infant Toddler Observation Scale, or TIPITOS, is for the infant toddler fidelity measure. We measure behaviors. We measure program actions related to challenging behavior, and then we work with programs to monitor child progress and to use a child outcome measure. Next slide, please. So Minnesota has been collecting all that data now for 5 years, and this shows their scale up and sustainability. So if you will remember, they started with 3 demonstration sites. They've added 12 to 14 sites every year, so they now have 53 programs adopting the pyramid model. They have 37, and remember they started with 10. They have 37 master cadre training and technical assistance experts. So they have built a massive amount of expertise within their state. And they have 98 people providing coaching, individual coaching to practitioners within their programs. They have 193 classrooms working on the pyramid model and over 2,800 children served. These programs represent school readiness classrooms, collaborative early childhood special ed and early childhood programs, early childhood family education programs, Head Start classrooms, center-based child care, and home visitor early intervention programs. Next slide, please. So the resources that Mary Louise mentioned, the training resources and lots of other resources are available both on the CEFL website and the TAXI website. And new materials and particularly the state work information is also on the Pyramid Model Consortium website. Thank you.
Thanks so much, Barbara. Next, we have Deborah Perry from Georgetown University, who's going to give us the 101 Introduction to Early Childhood Mental Health Consultation. Deb?
Thanks so much, Chantel. Well, it was so wonderful, Barb, to hear about all that work that's gone on in Minnesota. And thank you so much, Mary Louise, for that excellent overview of the teaching pyramid. I think from my point of view, early childhood mental health consultation is so complementary with the pyramid model. We know that nationally a lot of early childhood mental health consultation programs really view their work through a pyramid framework, thinking about what kinds of universal strategies teachers and families and even home visitors can use for promotion and prevention and supporting those children, as Mary Louise said, that are at the top of the pyramid who may have more intensive needs. I think also in a lot of states, early childhood mental health consultants are promoting the use of these strategies in classrooms, and so I think this is a really nice complementary approach. So I put this slide in the top of my deck. I know you guys covered this in the first webinar, but the preschool, Walter Gilliam's landmark study of pre-K expulsion really, I think, helped catalyze a lot of interest in states to expand their mental health consultation efforts. Next slide, please. And one of my favorite findings from that study was really this slide, which shows that for those classrooms where there was on-site behavioral support, a mental health consultation, to those teachers, the expulsion rate was cut nearly in half. And you can see it's sort of a dose-response relationship. So those programs that had on-call access to a mental health consultant had fewer expulsions, but really having that embedded person who's really seen as a part of the team is what Beth Green's literature really suggests, was supported with decreased expulsion rates. So that's sort of the link here. So as Chantel said, I'm supposed to do the 101 of early childhood mental health consultation, and so at its fundamental level, mental health consultation is a collaborative partnership between someone with mental health training and those folks who are working on the ground with young children and their families. And so much of the research that I'm going to talk about today has been from early care and education sites, child care in particular, but pre-K as well. But there's a growing evidence base around mental health consultation and home visiting that's very much being supported by the Substance Abuse and Mental Health Services Administration's Project Launch. A lot of really terrific work going on there. And at its core, mental health consultation is focused on child-level outcomes, so social, emotional, and behavioral health and developmental outcomes for very young children. But it does that by really building the capacity of those teachers, home visitors, family members to understand the influence that their relationships and interactions have on young children's development. And it's really through a mental health lens that this work takes place. And we're going to talk about this in a second, but in many ways, the catalyst here is building teachers and home visitors and families' ability to reflect. In many ways, like what Mary Louise said about what them helping to understand the meaning of children's behavior, but also to reflect on how their social, emotional, and mental health wellness affects children. I really liked when Mary Louise said, when teachers do better, kids do better. And the parallel here is when teachers feel better, children feel better. And so really focusing on the adults and building their capacity to promote those environments and relationships that support young children. And mental health consultants do a number of things that help support teachers building their capacity. So they will conduct observations, they will help facilitate screening, particularly in Head Start and early Head Start. The mental health consultants often support teachers conducting screening, but then also interpreting the results of those screens, talking to families about areas of concern, and identifying children with or at risk for mental health challenges so that they can really support those children early on, and again, through building adult capacity. Next slide. Generally speaking, when we talk about mental health consultation, we think about kind of two approaches that are not mutually exclusive, but it's often the case that a mental health consultant will be called in to work with a teacher or a family around the concerns about a specific child. And we generally refer to that as child or family-centered consultation, and there an individual child's concerns really motivate the array of services and supports that that mental health consultant will provide to that teacher. And next slide. And then another way that mental health consultants can be asked to enter into a classroom or a program is around concerns about the sort of social emotional climate of the whole classroom, or in some cases the whole program. And Barb talked about kind of program level implementation of the teaching pyramid, and we see the same kinds of parallels here. In that case, you might see the mental health consultant working with the child care director to really figure out policies around preventing preschool expulsion. How do we do that on a program-wide level? How do we promote staff wellness? One of the things that we know in child care, for example, is that we have a high level of turnover in teachers. And from young children's developmental standpoint, being able to form lasting relationships with adults in addition to their families, but to other important adults, is an important thing that we need to be aware of. And so reducing staff stress and staff burnout and staff turnover by paying attention to the adult's mental health can be really important. And I think, again, supporting reflective practices, whether it's in the individual teachers or helping the director provide more reflective supervision and support to her team is really important. Next slide. One of the things that's very unique about mental health consultation is that often the mental health professional needs to really shift the way they approach their work. When we train people to be mental health professionals, they generally see themselves as clinicians. They train to be either an adult mental health provider or a child mental health provider. And mental health, early childhood mental health consultants need to actually be able to bridge both worlds, and they need to adopt what we call, Khadijah Johnson coined this term, a consultative stance. And a consultative stance means that the mental health consultant doesn't go in and act as if they are the expert. They come in a partnership, acknowledging that the teachers and the families and home visitors have a wealth of knowledge about the children and families that they're working with, and that they come as a partner to this endeavor. And so a couple of ingredients of a consultative stance is wondering instead of knowing. So I wonder what he's trying to say when he's I wonder what that little guy is trying to say when he's hitting his friends instead of, you know, does he need some other strategies for entering a peer interaction, for example? Often, because we're talking about infants and very young children, speaking for the child, so giving voice to the child's concerns, and then also really attending to the subjective experiences of other adults and children in the room. And those are some of the characteristics of being more reflective, slowing down and reflecting on how the adult might be interpreting the child's behavior in ways that were not intended. Next. What we know, though, also is that mental health consultation is not therapy. It's therapeutic, but it's not therapy. And so the mental health consultants are not there to do a formal diagnostic evaluation. They're not running therapeutic groups, but they're helping to support those children getting that additional linkage to those services. I will say that in some rural parts of the country, those lines get a little blurrier because there may not be another specialized mental health professional in the area, for example. But when mental health consultants are doing this work, they know when they've stepped out of a consultant role and into more of a clinical role. But in general, we like to see those things separated. Next. I wanted to put out here sort of our theory of change, and this theory of change has really evolved over about the last 10 years, where we've very systematically looked at the research and evaluation literature about the effectiveness of mental health consultation in a variety of areas. And so you can see here that the theory of change is that the mental health professional really partners with early care and education providers and families by forming an alliance and building trust. Barb mentioned from implementation science, we know that adult behaviors don't change as a result of training. And what we also know from a lot of research is that people are reluctant to try new things or change their behavior unless they feel safe to do so. And so a mental health consultant can provide that kind of safe place for providers to try new things, to adopt new strategies, to take a chance on doing something differently. And so that alliance and that trust building is sort of one of the catalysts for that kind of behavior change. Through that, the mental health consultant is able to build capacity in providers and family members by helping to increase knowledge and skills and also increase that reflective functioning, so that we really see that that's one of the key ways that we think mental health consultation impacts suspension and expulsion, because we know that there are systematic biases in young boys of color being expelled at higher rates than their peers. And through that reflective functioning, the mental health consultant can get at some of those biases that may be operating inadvertently in the background. And then we see that this leads to actual changes in providers and family level practices. And that's how we get to those child level outcomes, which are so important to policymakers, and also linkages to other services. Next. So this is a summary of the research literature in this area, and what we see very consistently is that mental health consultation is associated with, consistently, with decreases in children's externalizing behaviors in particular. One of the things that I always like to say about that is not that we don't think mental health consultation can help kids who are internalizers, those who are shy or withdrawn or anxious, but it's not typically those children who come to the attention of the mental health consultant, because teachers may not see those behaviors as challenging as externalizing. And one of the things we see as mental health consultation, mental health consultants work with programs, is that more of those internalizing kids are identified and strategies can be mobilized for them. But it's through those reductions in children's behavior problems that we think we see some of the reductions in suspension and expulsion. We also see very consistently improved dyadic relationships and attachment. Many of the research studies use the Devereaux Early Childhood Assessment, the DECA, which has an attachment subscale, so we're able to really look at that directly. And I think, interestingly, and especially in this kind of policy climate, we are also glad to see that there's been some research, I think in the Michigan study that Mary may talk about next, that reduction, early childhood mental health consultation was also associated with reduced missed work days for parents who are not having to come and pick up their child early from the director's office. Next. We also, because it's a multi-level intervention, see very good evidence in the research of changes in provider-level outcomes. And so we see that providers are able to report really stronger skills in terms of supporting social emotional development and behavior management, again, sometimes through implementing some of those teaching pyramid strategies. We also see improved quality in terms of child care in particular, where we see better teacher-child interactions and better staff interactions. Those outcomes come from a measure that Walter Gilliam developed called the Preschool Mental Health Climate Scale, which really gets at some of the sort of more classroom-level changes. And then we also see in the research literature reduced staff stress and turnover. We saw that actually in some of the work we're doing here in DC at the Healthy Futures program, where mental health consultation was associated with lower rates of turnover in the classrooms that they were working in. And I think, again, from a policy relevance standpoint, seeing improvements in terms of class scores in childcare is really important as childcare and Head Start really look at trying to maintain good quality in their programs. Next. We also see changes in terms of program level outcomes, and by this I mean really having the child care directors implement more supportive policies, particularly around preschool expulsion prevention, increasing reflective supervision for staff both in home visiting programs and also in child care. Some of the things I mentioned earlier about stress and burnout and turnover, and then ultimately improved attachment and school readiness for children. Next. And then finally, really thinking from a systems level, how does mental health consultation kind of impact systems? We see that often mental health consultation can be a catalyst for programs doing more systematic, ongoing developmental screening, really improving their referral and follow-up strategies so that kids are getting connected to early intervention, Part C, or preschool special education, or specialty mental health services as needed, and really being able to kind of provide that wraparound for kids. Also, I think mental health consultation is an important strategy for kids who may already have a diagnosed delay or disability, being able to be maintained in inclusive settings. So helping teachers who may not be trained in special education have better strategies for maintaining children in their programs. Next. And now I guess we're going to turn it over to Mary, who's going to talk about the Michigan experience with early childhood mental health consultation.
Great. Thanks, Deb. So hello, everybody. My name is Mary McCrane, and I'm an infant and early childhood mental health consultant with the Michigan Department of Community Health, Division of Mental Health Services to Children and Families. I was the program director of our statewide early childhood mental health consultation program for over 10 years, and it's so exciting to share some of our lessons learned with you today. You've heard so much already. I'm just going to try to add some practical ideas for you all to think about This is such an incredible opportunity, I think, for all of us to explore really innovative ways to support the mental health needs of young children. And it feels like we've got this resounding opportunity to turn this trajectory of lifelong challenges around really early, perhaps even sometimes before expulsion occurs, and that's our hope. Next slide, please. So I wanted to start out by saying one of our lessons learned, I think, is that if we want to create a really strong support system around children's mental health, it takes an effort of partners. So to support young children, I know that these efforts can really be strengthened when they're considered within the context of a systems approach, which you've heard already. And when all of our cross-system partners see and value the need for early childhood mental health services, so we all become champions around the table, as Deb mentioned, looking through a mental health lens. It's challenging to do this kind of work in isolation, and we really know that everybody has a hand in building social and emotional wellness. The teachers that touch babies and toddlers and preschoolers in a classroom, WIC offices, primary care practices, home visitors, child care, we can all own it together, and we're more likely to really sustain something strong on behalf of kids and families when we're blending and braiding our efforts together, which includes funding. So I know for us, consultants often work with children and families in child care who are linked to Part C, at times mental health, public health, and school systems. Next slide, please. I know we've been very strength-based, and that's so purposeful, but like many of you listening today, you may be wondering, if you don't have these kinds of services or supports yet, how are we ever going to get started? Or if you've got them, perhaps you're wondering, how can we strengthen what we have? I know that our state has had and continues to have some challenges and barriers across our continuum of care related to mental health. But that being said, we have some great achievements as well. And I'm just going to share a piece of information that a mentor of mine shared, Roxanne Kaufman with Georgetown University, who is one of the pioneers of early childhood mental health policy, said to me that if you keep working on a plan, opportunity may knock on your door and you will be primed to answer. So even if you don't have the funding and everything in place right now, the more you can plan and be ready, the better. So in our state, we had some fragmented messages. So many agencies providing professional development around mental health needs of young kids. Often there was no coordinated and consistent effort, leading often to duplication of time and cost and misaligned messages. Like others, we often have a lack of funding. In fact, we had a 2011 policy report that was put out by Michigan's Children, reporting that less than 1% of early childhood funds in Michigan are spent on social and emotional health services, less than 1%. We often face access issues. When somebody does realize that a child is needing help in a community, sometimes they have nowhere to turn because there's nobody with that early childhood mental health expertise. Or when there is expertise, families may not be able to get access into the system. Next slide, please. So what do we do about it? And you've seen and heard about the different pyramids, promotion, prevention, intervention, and so forth. So before I jump into early childhood mental health consultation, I just wanted to tell you about a few quick things we've done to create a less fragmented system, starting at workforce development for those working with babies and young children. So one activity that's been successful is the development of a universal social and emotional messaging toolkit, part of a campaign. Through a SAMHSA-funded project launch program in Michigan, we formed a state ad hoc committee on social and emotional messaging that included families and clinicians and so forth. And we developed a toolkit that includes a social and emotional health guide for families with children birth to 8, a social and emotional fact sheet that includes some policy recommendations, and a scripted social and emotional PowerPoint that can be used cross-system. All of it's free. Anybody can download it, and we're creating a shared message. We provide a cross-agency social and emotional coaching series through a partnership between Michigan's Department of Community Health and Education. So 2 agencies blended funds to provide no-cost, ongoing, web-based training and coaching for infant and toddler professionals across the state to include home visitors, Part C, home-based providers, early care and education. So again, just bringing a continuity in terms of our knowledge and our approach across the state. The modules are adapted from the CEPL framework that you heard about earlier, and we've incorporated some other reputable research-informed resources related to adult wellness and resilience. All content is aligned with our infant mental health endorsement competencies as well. Next slide, please. So now on to our history of early childhood mental health consultation. Our project began as the Child Care Expulsion Prevention Program. Michigan began developing a model in the mid-1990s through the visionary work of a woman named Betty Tableman, who some of you on the line may know. She's our policy guru for children's mental health. Betty heard about preschoolers getting expelled in the mid-90s at a conference, and she came home very determined that we were going to do better for our kids, and she gathered mental health prevention dollars to fund 6 seed projects within community mental health agencies to not only study pre-K expulsion rates in the first of its kind pre-K expulsion study, but to actually do something about it. So it's hard to believe that almost 20 years ago, the efforts of mental health consultation grew from a foundation of relationship-based practice and family-centered care. So our consultants began trying this work on, stepping out from one-on-one clinical therapy, as Deb Perry mentioned, and moving into classrooms and homes to provide prevention, and they absolutely loved it. So shortly thereafter, our Michigan Department of Community Health partnered with our Department of Human Services to serve high-risk child care sites serving babies and toddlers through the use of child care development block grant funds, which were earmarked for infant-toddler quality. So we began to grow from 6 projects all the way up to 15 agencies serving 31 counties across the state, and child care providers were 100% in, families as well. I'd like to say we had this wonderful thought-out theory of change, but we built our model from the ground up and finally put together all that we found working in the early 2000s into a guidebook that all of our 44 consultants across the state had a hand in developing. Next slide, please. So what did we do? I think that's what a lot of you are probably wondering about. We really filled a major gap in our state. If you look at the pyramid on the screen, we've got kids that were struggling in child care that didn't meet criteria for mental health intervention, but were not succeeding in a group setting. About 27% of children referred showed externalizing behaviors like biting, hitting, kicking. Others, regulatory issues such as inability to focus, attend, and follow directions. A bit under 20% ended up having developmental issues that led to outward behaviors, but most compelling perhaps is we began to have a growing percentage of children that began to grow with those internalizing issues, sad, withdrawn, those kids who ultimately fall through the cracks and who we just don't pick up on until much later. Our consultants also realized that infant mental health endorsement and clinical expertise was critical as they began to uncover adult-to-adult relationship issues, sometimes a general sense of malaise and secondary trauma being recognized by the adults caring for children that were living in trauma and challenging neighborhoods, as well as children with really complex lives coming out of foster care and into their 3rd or 4th care setting by age 2. So in fact, close to 66% of our kids served were birthed through the age of 3, some already having been expelled from 3 to 4 sites. Not a good way to set up readiness for success. And Linda stated earlier that it's a ripple effect. I had mothers saying that they would dread the phone ringing at work because they knew it was going to be the provider saying that if you don't pick up your child, you know, we're going to expel. So next slide, please. So our model, again, this is all written in a guidebook. I can't go into all of the details in a short webinar today, but I'll give you some quick facts. Through the Child Care Development Block Grant Funds, we serve licensed child care providers, so center-based, group and family home providers, relative and daycare aides. Those were the places our babies and our toddlers and our preschoolers were. So we focused on getting to kids as young as possible, and we created modules for the general public so we could build relationships and get people comfortable with referring, and then things really took off. Next slide, please. So as our model matured, we developed a set of cornerstones, and I think this is kind of important when you're thinking about developing a model or an approach. The cornerstones allowed us to maintain fidelity to a model, yet a model of quality, but also offered enough flexibility to meet children and adults where they were at. Consultants, supervisors, and our funder wanted to know, what do you do, how do you do it, and is it working? And that's what this fidelity model really helped us to do. So I won't pull out all of the details, but just a few things I think I wanted to point out is, again, like Deb mentioned, our consultants needed to be master's degree mental health professionals. In our state, we have infant mental health endorsements, so we required that as well. So they were going in with this context of relationships and understanding of all of the multiple levels of relationships and impairments that people could be dealing with. You can see our caseloads and so forth. We provided child family center consultation, programmatic consultation. We required that every consultant get reflective supervision, so they were holding on to a lot that all of the adults and children were holding on to, and they needed somebody to also share this work with as well. And then we had a state-level consultation piece as well. I will say that in terms of state-level technical assistance, the kind of specialized support and intention behind it is what really supports will and stride of all of the teams and the quality. So we provided monthly supervisor calls, quarterly in-person meetings, ongoing coaching and shadowing, and a listserv. So we stayed connected, kept the relationships going. Next slide, please. So I'll just talk quickly here about evaluation. I think one of our lessons learned is start with evaluation, build it in from the very beginning so you can show that what you're doing actually works. We used a formative and summative mix, and you can see the results from what we found on the screen. Our full report is, I think, over 200 pages, believe it or not. You might want to read the executive summary, but bottom line is children's social and emotional health got better, challenging behavior decreased, parents missed less days at work, their stress decreased, and they've had a significant moderate increase in their feelings of empowerment of parenting their child. So next slide, please. The good news, as Deb Perry shared, is we have the science to show that mental health consultation, when done with fidelity, works, and we know how to do it, but it's complex. So I spent most of my time talking about that prevention level in mental health consultation, but if we think about a full system, building our workforce, building prevention, there's going to be those 5 to 7% of children who may need more intensive treatment. So in our state, we also worked on that, and we got a stakeholders group around the table to revise our Medicaid criteria for children birth to 47 months to ensure consistency in determining eligibility for mental health services across the state using the diagnostic classification system for birth to 3. Additionally, we put into place policy that any person in the state receiving state funds to provide home-based mental health treatment must have a minimum of a level 2 infant mental health endorsement. So we're building capacity of the workforce in the field that no matter where a family or a child goes, they're going to have access to good quality service and people that get babies and no toddlers. Next slide, please. You may have noticed that I've talked a little bit about our work in the past tense, and sometimes leadership and funding shifts. So shortly before our evaluation was completed, some of our funds were shifted into other priorities, but we were able to keep some of our services afloat, and we've had new opportunities through Project Launch that's helping us to integrate new social and emotional efforts through the Cephalon pyramid model, along with early childhood mental health consultation efforts, which you can see on the screen. And then lastly, we did receive a Race to the Top grant, and due to our historical approach with Cephalon and mental health consultation, we are going to begin efforts to roll up social and emotional prevention strategies as a really important piece of our early learning system. So if you don't see the how, it's worth it to have a plan, and you'll be ready when opportunity comes along. So I think I have run out of time, and you can see my lessons learned there on the screen, but at this point I think I'm going to turn it over.
Thank you so much, Mary. So next up we have Maria Seymour St. John, who is the Infant Parent Program Director at the University of California, San Francisco, and she's going to talk to us a little bit about diversity-informed infant mental health tenets. And we thought it was really important to include this as part of the webinar if we're talking about expulsion and suspension, because we know the social, emotional, and the behavioral and the workforce capacity is really important. But we also know that we see racial disparities, and we need to talk about diversity-informed practice. So with that, I'll hand it over to Maria.
Thank you very much. And if we could have the next slide, please. So I want to begin by thanking and commending the Departments of Education and Health and Human Services for issuing the gorgeous and righteous policy statement that this webinar is arising out of. I'm participating from California, where we're experiencing, as you probably know, the driest drought in state history. And so you'll understand what I intend to convey when I say that reading the policy statement after decades of work in the early childhood field was like experiencing the coming of life-giving rain. To situate myself a little bit more precisely, I will say I'm Director of Training at the University of California, San Francisco Infant Parent Program, which is an infant and early childhood mental health program offering direct service and training in the areas of perinatal mental health services, home visiting family support and intervention, and early childhood mental health consultation. And it's an honor to be following the prior panelists who spoke so movingly about the importance of some of these interventions across the nation. The Infant Parent Program is based at San Francisco General Hospital in the Mission District. And the images on the slides that I've put forward are drawn from the community-generated murals which adorn the walls of this densely populated and incredibly culturally diverse neighborhood and city. We've moved on to the second slide, which lists the names of my collaborators on this project. I have the privilege of sharing today a body of work that is not my own alone. The diversity-informed infant mental health tenets were collaboratively generated by a group of infant and early childhood practitioners from across the country, and the project owes its existence to the Irving B. Harris Foundation, without whose support we literally wouldn't have had a way of coming together to collaborate on this vital endeavor, drawing from our diverse experience across the nation. Next slide. Oh, thank you. You're ahead of me. So the diversity-informed infant mental health tenets are a set of what we think of as aspirational guidelines. Actually, can I ask you to go back to the prior slide for a second? Okay, go forward. Thank you. In a minute, you're going to be given the address for the website where you can find the tenets, and I encourage you to visit it today and regularly going forward, as new and related tools and materials will be added as they're generated.
Maria, are you still there?
Hello?
Hi, are you still there? Sorry, we lost you for a second, I think.
Oh, okay, yes, I'm here. Can you hear me?
Yep.
Okay, sorry for that. So the tenets are a set of 10 affirmative statements, and each one is both simple and multifaceted, that is intended to support and guide us all in the multicultural and interdisciplinary work in the infant, family, and early childhood field. They're designed to support each of us in our own individual professional development, to be instrumental in workforce development, to serve as building blocks in developing inclusive agency and program standards, practices, and policies, and to be instrumental in systems change. Next slide, please. I'm going to talk a little bit about some of the key terms that you're going to see in the tenets themselves. So the term diversity-informed practice follows from our colleague Chandra Ghosh Ippen, who contributed to the generation of the tenets. And we use this term rather than, for example, a term like cultural competence in order to underscore the fact that diversity is an ever-present and ever-evolving phenomenon of those served and also those serving alike. I want to say a little bit about the term privilege. We think of this as unearned status, power, and authority. And we draw from the work of Lena Benjerry Brown, who states, privilege and discrimination are made possible because of one another. Both are products of a paradigm and a mindset defined by hierarchy and exclusion, in which value is accorded to a few at the expense of many. Benjerry Brown goes on to say, in my pre-immigration life in India, I had the experience of a social context in which privilege came for no good reason. In my post-immigration life, I have the experience of a social context where discrimination comes for no good reason. So we feel that this quotation is very helpful in understanding the way that privilege and discrimination are tied together and helps as a port of entry for accessing, thinking about how implicit bias negatively impacts us in our work. The term infant mental health is used in the spirit of the World Association of Infant Mental Health Handbook definition, which states that infant mental health is the ability to develop physically, cognitively, and socially in a manner which allows small children to master the primary emotional tasks of early childhood without serious disruption caused by harmful life events. Because infants grow up in the context of nurturing environments, infant mental health involves the psychological balance of the infant-family system. And we would expand that for our purposes in the conversation today and more generally, not only to include the family system, but as the previous panelists have described so beautifully, all of the systems of care in which infants, small children, and families are embedded. And finally, the term social justice, which we understand as promoting a just society by protecting human rights, promoting equitable treatment, and ensuring fair access to resources. In the history of our work generating the tenets, it's important to say that we originally had yes, thank you, thanks for advancing the slide. We originally had two separate working groups, one of which was tasked with doing a review of the literature and a distillation of foundational tenets of infant and early childhood work. And the other group was charged with generating some diversity-informed practice principles. And at a certain point in these parallel play processes, we realized that it was actually unethical to proceed in this manner, as though diversity issues could be handled as non-foundational, or conversely, as though foundational tenets could be identified that had nothing to do with diversity. And that, in fact, the two projects were one and the same. So in a nutshell, early childhood work is social justice work. Next slide, please.
Maria, just as a warning, we're at about five more minutes to go.
Okay, I'm gonna move through these very quickly so that we have time for some questions for all the panelists.
Sounds good. Thank you.
I'm going to say a little bit about number one, and then we'll move quickly through the rest. So tenet number one, self-awareness leads to better services for families. Professionals in the field of infant mental health must reflect on their own culture, personal values, and beliefs, and on the impact that racism, classism, sexism, ableism, homophobia, xenophobia, and other systems of oppression have had on their lives, in order to provide diversity-informed, culturally attuned services on behalf of infants, toddlers, and families. So this tenet is number one for a reason. Early childhood work is the most important and the hardest work there is. That's my contention. Infants and small children need absolutely everything we have to give and more. So thank goodness for the village. They listen to what we say and they hear what we stifle. They feel what scares us, and they know where our buttons are. In fact, buttons are interesting and attractive to infants and small children. They go right for them. They also pull hair and earrings and ask direct, exposing questions. And if they're old enough,
That is, if they're old enough to talk, and they will tell us if our breath smells like coffee. In short, they bring us to the brink, and they sometimes push us over. Anyone working anywhere near a small child needs to have protected space and time for reflection about our own fault lines, blind spots, dirty laundry. We all have these because we are human, and we all need to keep learning about our own wounds because they are constantly being inflicted afresh or reawakened. What we don't know about ourselves will harm the children and families we are striving to serve. Next slide. I'm going to actually skip through this and direct you to the website to review all the slides when we have more time. But about slide number 3, I want to say that Patricia Hill Collins offers a theory of intersectionality that sees the systems of oppression, including racism, classism, homophobia, misogyny, etc., as interlocking, not additive. And she states, each system needs the others in order to function. If you'd please move to slide number, tenet number 4, recognize and respect non-dominant bodies of knowledge. I just wanted to tell a little brief story of my very first home visit 25 years ago when I knocked on the door of an African-American family with my badge prominently displayed on my breast, which I thought was a symbol of my impressive knowledge and professionalism. And the door was opened by Ruby, an African-American girl of 3 who called over her shoulder, "Mama, there's a white lady at the door with a picture of herself around her neck," which story I think describes the importance of the non-dominant bodies of knowledge that even very small children bring to the interactions they have with us. Next slide, please. Honor diverse family structures. I want to call attention to this one too, and to suggest that it's important for all of us to inventory the verbal and nonverbal representations that we have of ourselves and our agencies, for example, agency logos, etc., to make sure that the representations of families that we're offering as images of the work that we do and the spirit in which we do it are indeed inclusive. Often we'll be surprised to see the heteronormative bias or the dominant cultural bias in other ways in our very own literatures and images. I think in interest of time, I'm going to ask you to move quickly now to slide number 17. So we preserve a few minutes for questions from the participants. This is the last slide, thanking everybody for participation in this effort. I wanted to suggest a few ways that the diversity-informed tenets may be used. As you can see, they're truly generated through a grassroots effort, and they can be used in both small and large ways. So bringing them into staff meetings or bringing a single tenet into staff meetings for discussion, bringing them to board meetings, using them for self-assessment either at the level of the individual practitioner or at the agency. How are we doing in relation to this set of 10 tenets? Also incorporating them in teaching and training. And many people have spoken on the panel about the importance of reflective practice and instituting reflective supervision. And I want to say that many people who have trained on the tenets have reported that they find them very useful as a tool in these kinds of reflective practices. I want to conclude by noting that the policy statement and this webinar is specifically directed at reversing the trend where brown and black boys are targeted for suspension and exclusion. And I want to quote Toni Morrison, who talks about the legacy of slavery in this country, with which I believe that this institutionalized form of racism is consistent. Morrison talks about the collective need to allay internal fears and justify external exploitation that slavery was an answer to. She says, black slavery enriched the country's creative possibilities, for in that construction of blackness and enslavement could be found not only the not free, but also, with the dramatic polarity created by skin color, the not me. The result was a playground for the imagination. What rose up out of collective needs to allay internal fears and rationalize external exploitation was an American Africanism, a fabricated brew of darkness, otherness, alarm, and desire that is uniquely American, end quote. And I want to suggest in closing that the policy's call to action around expulsion is, in a way, a new emancipation proclamation. Expulsion starts, I contend, within the practitioner, and inclusion is likewise guaranteed from within. So I'm going to end there so that we have, hopefully, time for some questions and comments from participants. Thank you.
Thank you, Maria. So we will go a couple minutes over just to get to a couple questions at least for the presenters that can stay on the line. You can go ahead and chat your questions, type your questions in the chat box, and we'll try to get to at least 2 of them. One of them that came in earlier is for Barbara and Mary Louise both. So one question we got, how did Minnesota fund the statewide pyramid model? And what was the cost per child? And then kind of related to administration, what state agency runs the system?
Hi, this is Barbara. Well, that's one of the things, that's one of the reasons that we strongly suggest a strong multi-agency state team, that they can participate either by actual funding or in-kind support. I can't answer the cost per child. I could certainly look into that if there's a way to get back to folks. And then the third question was, who's the lead agency? The lead agency that brought the team together and that has coordinated the work is the Minnesota Department of Education.
Great, thank you. One more question that came in, and we'll wrap it up after this question if we don't get others. And this could really go to all of you. Somebody asked, what if the family can't promote social emotional development at home for whatever reason? How do you work with families in building and strengthening those partnerships?
Well, this is Barbara. I'll just jump in real quick. The pyramid model has 2 family training and support models. One is for the preschool-age child and one is for the infant toddler, and those are specifically for increasing the competence of families.
This is Mary. I'll just quickly say that we could talk about this for a very long time, but I think it gets back to those relationships, and if we can't get to the family, it's going to be hard to get beyond that. So I know through mental health consultation, we can put a lot of emphasis on really supporting the family through what barriers they're facing and what needs they have until they're ready to move into a place where they can then focus some of their efforts on the child parenting. But some parents haven't gotten some of those relationship experiences early in life, and we sometimes are the model for promoting that. So it takes time and it takes effort, but it can be done through relationships, I would say.
And I'll add from the diversity-informed tenant perspective that often we find that when we're having a hard time engaging a family, some of the barriers to access can be located and addressed within the providers and the practitioners or at the agency level, and that it's important to start by questioning where are we failing in the outreach effort, as opposed to where is the family failing to take up what we're proffering.
Great, thank you. So I want to close quickly by just directing folks to a few additional resources here at the federal level. HHS will release a document really soon on the several different HHS federal funding streams to support early childhood mental health consultation. So we will send out an e-blast to folks when that becomes available. You've heard the policy statement referenced many times, so here's the link for that for those of you who haven't seen it. Our Department of Education's Office of Special Education Programs has the Positive Behavior Intervention Support TA Center, which also has several resources. And finally, HHS and ED's Birth to 5 Watch Me Thrive initiative, which provides just a whole host of really rich resources on developmental and behavioral screening. And in closing, thank you all again for joining the third webinar. Next week at the same time, 1 p.m. Eastern, we'll host the last webinar, which is going to look at data systems and how we can use data to really track and reduce expulsion and suspension. So thank you again to our presenters, and thank you to everyone who joined today. Have a great day.
Thank you.